So hello, good evening, everyone. And thank you very much for joining the third session of LEJ ENDO. We started LEJ ENDO in January this year, and the idea was to make journal clubs less boring, if you like. So we're all busy clinicians, and often we don't have time to read papers that come out. And we thought it would be nice for our team to read through interesting papers that have been published recently and choose some of those and then present it to us. We also, each month, will have two selected papers that we think are particularly interesting, and then we invite their authors to come and present their own work, and we think that's been going very well. But this month, we are able to announce a very exciting development in LEJ ENDO, and that is that we have joined forces with EEL, European Endometriosis League. And it's actually very well timed because one of our special guests is the president of EEL, Professor Harold Krentel from Bethesda Hospital in Duisburg. So from this month, our LEJ ENDO monthly journal club will be done in collaboration with the European Endometriosis League. And I'm very excited to have Harold here. He will be presenting his work on morcellation, in-bag morcellation, and time that it took during surgery. Our second special guest is also really special, Professor Carmona from Barcelona. And his work, he may not know this, but I've been following his work for a number of years. He has published plenty of very high quality papers, and he has really contributed a lot to endometriosis. And this particular work is something that I have found extremely useful and have read it a couple of times, and I thought it would be really exciting to have him. Professor Carmona is going to be our first guest speaker. But I will take a couple more minutes just to do some housekeeping. The first thing is to also thank Karl Storz UK for their support in setting this up and in promoting the journal clubs, LEJ ENDO journal clubs. Although we have accepted no financial support and therefore we have no conflict of interest, the support of Karl Storz has been technical and with the promotion and the graphic design, and we're very grateful to them. Just to introduce the team to you, this is the whole of the LEJ ENDO team at the moment, but the team is growing. Avril Bachi is my current fellow. Kyle Flesher is planning to join us from October as our fellow. Ben just recently finished his fellowship in October, and Mikey is now my consultant colleague at CMIC, both at the Lister Hospital and at St. Peter's Hospital, and Mikey has been my fellow before Ben. Just a couple of last things to say, because I know that we sometimes get patients on these journal clubs, to say that we are sorry if we use the language and lots of jargons that may not be understandable for you, but you need to also keep in mind that presenting a paper does not mean that this paper is now the answer. The way research works, the way science works, is that each piece of evidence contributes to the progression, and this is never the final answer. And sometimes we present papers that we may even disagree with the findings, but we still present them. This does not include Professor Krentel and Professor Carmona, because I actually like both of their works and the papers that they are presenting today. But we have in the past presented papers that we ourselves have some problems with. And the way science works is that we critically appraise these papers, and this is just a introduction for people to go and read the papers themselves. Now, from this month, we are doing something new as well. So we come up with a clinical question, and one of the CMIC team will go and find the answer to the question. Today, Ben has gone away and found the answers to one particular question. How can we use CRP in post-operative care of women when we do bowel surgery on them? So we're going to start with that. The structure of this 1 hour from now is going to be, we'll start with Ben's answer to the clinical question, and then there will be another little paper that Kyle will present. Then Professor Carmona will present his work, and then we'll go back to 3 further small papers, and then Professor Krentel will present his work, and then we'll have Q&As. And please use the Q&A button and stay until the end. There will be some more announcements for the end. Okay, Ben, do you want to start?
Yes. Can you see my slides?
Yes.
Yes.
So thank you so much for the introduction, first of all. Let me see if I can... okay, perfect. So, like you mentioned before, last month we raised this question about the role of CRP for predicting post-operative complication for deep infiltrating endometriosis. Avril found these really nice papers, and one is from the Bologna group from Serracchioli and Diego Raimondo, and was published in JMIG in 2022. And the second one is from Horace Roman from Bordeaux, and it was published in 2019. So they're slightly different, the 2 papers. The first paper talks about CRP as a predictive value for shave of deep endometriosis. The second one looks at segmental resection. So it's actually a really good paper because, as you can see, the number is impressive. We're talking about 294 patients, and we're not here to look at the complication rate, but ultimately of these 294 patients, we are looking at a total of 289 patients, and out of these 289 patients, the CRP was recorded day 5 for 580 patients, and at day 7 for 47 patients. And the reason why some patients got lost because, as we all know, some patients get discharged before day 7 following this kind of procedures. So in terms of complications, there is a significant difference in terms of CRP between non-complication and complications. When there are no complications at day 3, there is a mean of CRP of 38, which goes down to 22 and 23 respectively on day 5 and day 7. When there is a complications, in particular when there is like a early septic complication, the CRP goes up significantly to 63, 75, and 137 respectively between day 3, 5, and 7, with a difference of 25, 53, and 114 between no complication and complications. So what the Bologna group has done is an analysis to see if we could find a good cutoff in order to predict post-operative complications. So for a cutoff of 31, if we say 31 at day 3, we have a really good negative predictive value of 98%. So if someone has a CRP of less than 31, it's highly unlikely that there is any complication. The problem is that with a cutoff of 31, the positive predictive value is only 17. So the number of false positive is particularly high. So higher CRP of more than 31, it doesn't necessarily mean that there is a complication. With the cutoff of 52 is slightly better than positive predictive value of 44, so almost 50%, with a negative predictive value still very good of 98. In the second paper, when we look for bowel resection, and this is the paper from Horace Roman, they looked at bowel resection, including disc excision and segmental bowel resection. And again, the numbers is really impressive. We're talking about 303 cases in between segmental bowel resection and this resection. And in terms of early septic complications, the total number was 9.9%. They're looking into leaks and pelvic abscess or hematomas. And they've noticed a very significant increase of the CRP in these cases. As you can see, if there is no complication, the CRP is, the mean of CRP is 43 and goes down to 27, 22 on day 4, 5, and 6. If you have a fistula, the CRP carries on going up from day 4 being 182, day 5, 216, and 223. Also in early abscess, although it's slightly lower than in case of a fistula, you still have a significant raised CRP in comparison with no complications. So the team from France, after accurate analysis, managed to find a cutoff value for day 4. And with a cutoff of 100 of CRP, you have a really good positive, really good negative predictive value that is around 90%, but the positive predictive value is again quite low. So the number of false positive is quite significant in this case. What this team advise and suggest that if you do have a CRP of over 100 on day 4, you do have to consider further testing and exploration to rule out any early septic complications. This is what we found about the CRP. So
okay, and I don't know if Paco or Harold, do you have a cutoff, or do you use the CRP as part of the larger clinical assessment? You're on mute, Paco.
Sorry. No, we don't use PCR as a systematic evaluation in all patients, and we don't use this value for predicting the risk of ligation. In the last maybe 20 months, 1 year and a half, something like that, we are starting using procalcitonin. Procalcitonin is a very good predictor for in the second day after the intestinal surgery, mainly for resection. And we are using procalcitonin now.
Yes, I think that's actually a very, very good point. Procalcitonin is actually a very, very sensitive and specific test for leak, for bowel leak particularly. What about you, Harold? Do you use CRP routinely or not?
Yes, we do use the CRP levels. Yeah, in most of the cases of bowel surgery, patients leave the hospital after 4 days, and usually they are under the cutoff. We do CRP level every post-surgical day, and it's quite interesting because if you compare different techniques, like we have seen that in the studies of bowel resection, the CRP levels are quite different. So what we did in the last time was a nodular resection with a mucosa sparing technique, and the CRP levels are extremely low compared to disc or segmental resection. So I think it's interesting to measure CRP levels, and it's a good way to measure if everything is fine.
At least it's cheaper than procalcitonin.
Yeah, much cheaper. Yeah, procalcitonin in our unit needs to go to a reference lab. And the other thing to say is that, you know, clinical assessment is the most important thing. So these are all just one of many things that we look at. The examination is probably the most important, and then, of course, the patient's observations. Okay, that's great. And now we go to Kyle. Kyle, what do you have for us?
Grant, so I've got a paper published by a group from a tertiary referral unit at Sydney University with a special interest in managing symptomatic adenomyosis and fibroids using interventional radiology. So this is a small but comprehensive study that evaluated ongoing effectiveness in a group of patients that had initial improvement following UAE for adenomyosis. This initial study was published in 2018. To assess this, patients received a two-part survey. First off, evaluating symptoms of bleeding, pain, menopause, and their overall satisfaction. And then the second using the uterine fibroid symptom and health-related quality of life questionnaire, which is validated specifically for fibroids, but the authors chose because of the crossover in symptoms. Long-term clinical success was defined as patient satisfaction, rated as either happy or very happy with overall outcome, no recurrence of symptoms, and no need for further interventions. In this study, 90% have remained happy or very happy with the overall long-term outcome without recurrence or further intervention. And the authors conclude that the UAE can offer a potential management for women with adenomyosis who would prefer not to have hysterectomy or where this may not be suitable. So this next slide shows you their selection process and the flow chart. And we're looking at the boxed area where patients who had an initial clinical success then had long-term follow-up. Moving to the next slide, this table, if we just go to the next slide, Ben, this table shows the results for the specific symptoms and the quality of life score. And then on our final slide, the authors have done a very nice summary of why people reach long-term clinical failure. So that was partly due to recurrence of symptoms, patient dissatisfaction. One case number 3, became unintentionally pregnant 3 months post-UAE, and this pregnancy was complicated with hypertension, gestational diabetes, cervical incompetence, and PPROM, with subsequent labor requiring cesarean section at 33 weeks. So as said before, this is a small but comprehensive study, and in terms of what the authors want to do next, they'd like to look at a specific RCT for this.
Yeah, the problem of treating adenomyosis in patients who want to retain their uterus and can't use hormonal treatment is a really difficult one. So I have been in conversation with a group that have been using HIFU, high intensity focused ultrasound. And I know that Ben is going to present another technique in the second half of the procedure. I don't personally perform adenomyomectomies. I just, it's not a very scientific thing to say, but to me, it just is a very high risk procedure for pregnancy afterwards. But others do very successfully, and you know, I'm not saying it's the wrong thing to do, but at least I don't perform it. What do you do, Paco and Harold, for this group of patients?
As you say, it's a very difficult topic to retain the uterus in patients with severe adenomyosis. We prefer the medical treatment. And if it fails, we also go to surgery, conservative surgery. But it's a very you have very few cases in which we indicate conservative surgery. Mainly if the patient has her gestational desire fully accomplished, we prefer to recommend her go to the hysterectomy if the medical treatment fails.
Okay. What about you, Harold? Do you do adenomyomectomies?
Yes, we do. But you are absolutely right. It's high risk. There's no evidence. So actually, it's the last exit to do surgery on the uterus when there's adenomyosis. But I would begin a bit earlier, because what we need is a good diagnostic in adenomyosis. So the first thing is that we should diagnose the disease and include it in our treatment concept, either medical or surgical treatment or reproductive treatment. But it's absolutely necessary that we have a good screening on adenomyosis. Just include this to our screening on deep endo or peritoneal disease. And then we can counsel our patients in a good way, including this in terms of reproduction or pain management and surgical approach. But yeah, there are several possibilities to treat adenomyosis by surgery, and sometimes just by hysteroscopy, sometimes by laparoscopy, and of course there's also a place for open surgery, but this has to be based on a very detailed informed consent.
It's very interesting. We're going to present HIFU in the next 2 months. I went up to Oxford to see the technique. They haven't started doing it on adenomyosis, and we're going to start a pilot, hopefully. Basically, the idea is that you focus ultrasound energy in an area around the size of a grain of a rice, transabdominally, under the guide of ultrasound. It's a bit like MR guided focused ultrasound, but with ultrasound guided. And the idea is that you can actually treat the adenomyoma without opening the muscle. And the results coming out of China and the Far East are actually quite promising, but hopefully we'll be able to have a better look at it. Okay, so you can see that there is a poll there. You have already answered the other poll about in-bag morcellation, which relates to Professor Krentel's presentation at the end. But here is another poll for UAE and its place in your practice with adenomyosis. Okay, it's time now to hear Professor Carmona's work. Just as an introduction to his work, I've been going to maybe, I don't know, between 8 to 10 conferences a year in the last 10 years on endometriosis. And in every conference, there is always a big debate about the role of surgery in patients wanting to get pregnant, IVF or natural. Should we do surgery for the indication of fertility or not? And the research in that field has been very, very, how do I put it, heterogeneous. And I think Professor Carmona's work brings us one step closer to the answer. Please, Paco.
Okay, Shahin, thank you. Let me share my screen with you. I think you can see now my screen.
Yes, we can.
Okay. Yes, I am Dr. Carmona, I'm Paco Carmona. Thank you, Shahin, for inviting me. I am the chief of the hospital clinic in Barcelona, professor in the University of Barcelona, and also the current president of the SEUT, the Society of Endometriosis and Uterine Disorders, that you know is devoted to this disease and the disease of the uterus. Thank you for inviting me. In this paper, as Hin explained it before, we try to analyze the impact of the surgery on deep endometriosis fertility, to answer one of the millions part of this debate, this eternal debate that we have in the medical conferences. We published a paper I think 1 year ago in JMIC. It's a journal with 4.1 points in the last impact factor list. You know, endometriosis is a very, very frequent disease in which infertility is present in around 30–50% of the patients suffering the disease, and vice versa, endometriosis is present in up to the 50% of the patients with infertility. And the treatment of the infertility in those patients is very controversial. It doesn't matter if you look at the endometrioma, if you look at the superficial disease, if you look at the deep disease, the infertility treatment is always a controversy. There are some investigations, very heterogeneous investigations, as Shahin told before, that have found that removing deep endometriosis may increase the spontaneous pregnancy rate after surgery. And also some studies suggested that surgery before ART could be beneficial in order to increase the pregnancy rate. But on the contrary, other studies do not show any benefit for this first-line surgery before IVF. In fact, the ESRE, the European Society of Human Reproduction, in his guideline that last February, 2022, the 22nd, they say that the decision to offer surgical decision of deep endometriosis before IRT should be guided only by the symptoms of the patients and not looking at the reproductive outcome, because there is a lot of uncertainty of this approach because there are no randomized studies. So we try to compare and to make a meta-analysis comparing the reproductive outcomes in patients who had undergone surgery for deep endometriosis just before IVF. That means without giving the patients the opportunity to become spontaneously pregnant, and compare the results with patients who underwent IVF without the surgery for deep endometriosis, just for surgery just with the deep endometriosis in situ. And we try to analyze the results according to different types of surgery, complete or incomplete, bowel affectation or bowel involvement or not. And then we start a search, including all the papers published in the last 40 years in all languages, and looking at those databases that you have in your screen. We follow the PRISMA guidelines. We include the review and the Prospero. Sorry for the mistake. In the Prospero register, and it is the query that we use for the search. We're selecting all the studies comparing the reproductive outcomes in women with infertility and deep endometriosis who receive IVF with or without previous surgery for deep lesions, and if they receive the surgery, they didn't have the opportunity of becoming spontaneously pregnant. We include cohorts, we include case controls and also studies with control group, and unfortunately we didn't find any LCT or other meta-analysis or other previous meta-analysis we were found. And we try to analyze the primary outcome, the pregnancy rate per patient, and the secondary outcomes were the pregnancy rate per cycle and the live birth rate per patients. We'll include all the IVFs attempts and reported in the papers. We said that when there was usually the data were stated by two reviewers. If it was a draw, a discrepancy, a third reviewer opinion was requested. We tried to contact all the authors of the papers, and we got the answer of two teams that helped us in the interpretation of the data and give more data when needed. And we performed the meta-analysis following the Cochrane collaboration rules, using the review manager that was developed by Cochrane, the Cochrane collaboration. We follow the PRISMA guidance, and we calculated the odds ratio and the sensitivity analysis. We perform a sensitivity analysis. We try to measure the heterogeneity of the studies and the risk of bias using the day-2 statistic of the Refman in the same manner that the meta-analysis, and also we try to make the funnel plot to be sure that there was not a bias of publication. And there's the results. The main result is probably one of the most important is that we found 150 papers, but after we discard some papers because it was duplications, and we exclude all the records. At the end, we found only 12 papers with eligibility criteria for full text assessment, and then at the end only 4 papers were included in the meta-analysis. There was a fifth paper that can be used, but it was a lot of overlapping with another paper already included, and we exclude this one. There is the papers that we include in the meta-analysis, the paper of Pendifala in 2017, the paper of Paolo Bianchi in 2009, the paper of Musambot, and the paper of Robot also in the last very few years. And we try to look for other variables that may impact on the result. For example, the presence of endometriomas, or the presence of adenomyosis, of the presence of hydrosalpins. Only, as you can see, some papers reported the presence of endometrioma. Other papers was not reported the presence of endometriomas, or on the contrary, some papers reported the presence of adenomyosis or the presence of hydrosalpin. So it is a limitation of the study that is important to take it in mind. We try to review all the information about the theology of the infertility, and the most important result, the outcomes of the result was, in my opinions, were very clear. As you can see here, the pregnancy rate per patient, it was the primary outcome, was almost double in patients that had been submitted to period surgery before the IVF. The patient the surgery was undertaken, and then immediately after, the patients were submitted to the IVF, and then the pregnancy rate per patient was double in those patients. It was exactly the same in patients with the pregnancy rate per cycle, again, almost double, and the live birth per patient was 2.2 times greater in the patient submitted to surgery. All the results were very, very consistent. Always, it doesn't matter if the surgery was complete or incomplete. The incomplete surgery also has a beneficial effect on the pregnancy rate. When we include the paper with overlapping data, the paper by Capel that was not included in the first analysis, again, the results were still consistent with a very highest pregnancy rate per patient and pregnancy rate per cycle. This is a mistake, sorry. And we tried also to see if the type of surgery, or the type of it was digestive involvement or not. It was bowel involvement. And also the odds ratio for pregnancy rate was greater. The odds ratio for the pregnancy rate in patients without digestive involvement was also greater. So all the results were clearly favoring the idea that excising the deep endometriosis may favor the pregnancy rate for patients in IVF cycle. As you can see here, there was not a risk of bias, of publication bias, because the funnels plots were very symmetrical. And just to discuss and the most important points of this paper, this is the only meta-analysis assessing the effect of surgery of deep endometriosis in IVF, and showing that surgical treatment of the deep lesions improves the IVF outcomes. The explanatory mechanism for these results are not clear, but maybe the materials is the surgery may diminish the inflammatory ambience in the pelvis and may favor the implantation, may increase the quality of the ovum, the quality of the oocytes. Also that the abnormal levels of aromatase may also affect the endometrial development of receptivity. The oxidative stress may be improved after the surgery, and also for sure the abnormal anatomic conditions are restored, and then it may improve also the access of the ovaries during the oocyte retrieval. This is one of the studies that the evaluation of impact in a very specific cohort of patients. It's a very specific. It's not. We try to be the most homogeneous possible in order to extract the maximum information. The results are very consistent. All the analysis showed that the effect is positive, where there was no publication bias detected, and we follow very carefully the PRISMA checklist in order to perform the meta-analysis. We have also limitations. None of the included studies was RCT. For sure, it can increase the risk of selection bias, not the publication, but it can increase the risk of selection bias. Although one of the studies used the propensity scores technique in order to reduce this limitation, that it was not a randomized study. But again, all the outcomes were very objective, so it cannot be a misclassification. In all the cases, the endometriosis was diagnosed using strict imaging studies, MRI or transcranial ultrasound, and again the results were very consistent in all the studies. So this limitation is possible, but it can be not so important. Again, you can see that we use only 4 databases, but remember that we start to include all the papers. We start a review, the search from a long time ago, but the newest databases that are specifically for the crawler-based search engines that they use, like Google Scholar and so on. It can be also a problem. And so just to conclude, for sure, the results of this paper encourage us to recommend surgery to all patients before IVF, but I'm not sure, Shaheen, we can strictly recommend, strongly recommend surgery before IVF. We need some more randomized control trials in order to assess the type of surgery, the protocol for IVF, the pregnancy complications also we need to assess. Such RCT studies should control the age, the markers of ovarian reserve, the presence of other confounders like adenomyosis, hydrosalpinx, endometrioma. And we should also exclude subjective criteria for allocation of the patients. And I think we should, nowadays, we must indicate surgery or not in a very individual manner. We need to tailor the treatment for each patient. We need to evaluate the patients in multidisciplinary teams, in referral centers, and the management should be done by skilled practitioners, skilled IVF doctors, or skilled also surgeons. And let me invite you, if you are able to attend, the next congress is next week in Abu Dhabi of the society, and I'm sure it should be, we will try to make light on some of the questions that we are still having for this disease. Thank you for your attention.
Very
now
much, Paco.
open.
That was really interesting. You know, you're absolutely right. This is the most challenging, not the most, maybe one of the most challenging discussions that we have with patients. There is a lot to take in. It depends on what happened before. If somebody comes to my clinic who've had 3 failed IVFs, it's one thing, but if they are young and they haven't had IVF and they don't have symptoms, it's another. There is no prescription, but I think that your study is very optimistic. I think I find it very positive that what we always felt to be the case, which is if there is an abnormality that is causing inflammation and abnormal placentation and difficulty with all sorts of things that we know, it makes sense that if it's taken away, things are going to be better, but not every patient is the same. There are two questions from Jamal Fikri. I think you answered one of them. He's asking, is this meta-analysis, in this meta-analysis, did you exclude spontaneous pregnancy?
Yes, we did. We only include patients that they are going directly to the IVF surgery and then direct to the IVF, not allowed to try for spontaneous conception. It is a good point. For sure, it can be an option, but yeah, we need to be very to go straight to the point, and then we exclude this possibility.
Okay, and the second question also I think you've answered. Jamal is asking, knowing that operated patients have greater chance of spontaneous pregnancy than non-operated ones, is it correct to compare groups with similar number of MAR attempts, or should we offer more attempts to the non-surgery group?
You know that again, this meta-analysis, as usual, that's the norm when you make a research. You write a paper, and you have more questions at the end of the paper than before.
Yes.
In this meta-analysis, I think we can say that we have shown that IVF has more chances of pregnancy if you operate the patients, but it doesn't mean that you have to operate the patient in order to perform the IVF. So that if you operate the patient, it will have more. For sure, you can try more times if you don't operate the patient. Sorry, but I cannot answer this point. This question.
I don't think we will find the answer anytime soon.
Exactly.
Asmia Okoji is asking, could those who had surgery mainly for pain, who then went on to have IVF later on, being included to expand the research criteria? I'm not sure if I understand the question though.
Those who had surgery mainly for pain, who
went on to have IVF later on, included to expand the research.
No, I think the question is, okay, when was the indication for IVF performed? Before of the surgery, or was the surgery indicated by pain, or because of the infertility? I don't know. I cannot answer this question.
But you know, the one thing that this will show us is the very urgent need for us all to have one pool of data, that we are speaking the same language, we collect the same data, we use the same method for collecting the data, and that will really give us a lot of answers. And currently, unfortunately, we don't, but hopefully we're working on it.
But going back to the commentary that Karen did before about the diagnosis of adenomyosis, I think it's exactly the same. How we have a lot of times, I find a lot of time in my daily practice, a lot of patients that they are going to my hospital because they are infertile, and then we find the fertility. How many patients are submitted to IVF clinics and they have deep endometriosis and they didn't know? We need to make an effort on having a good diagnosis of the disease, of the presence of the endometriosis. We're using in this moment 3 or 4 different classifications of endometriosis, some of them including deep endometriosis and others not. But we need to, I totally agree with you, Sahim, we need to unify our language. We need to be sure that we are speaking about the same thing. We are including the same kind of patients.
Exactly. And just finally, because we're running out of time, Engin, our past president of EEL, saying that the problem is we do not know how deep endometriosis causes infertility, or if it causes infertility. And so it's been amazing. Thank you very much, Paco. So we've had 2 presidents at the same time in our
and one past president.
Yes.
Engin is here.
Yeah, and one past president. Yes, exactly. Okay, so let's go to our short articles before we go back to Harold. We are going to be running a little bit late. I hope people don't mind. I will really try to end maybe at 15:15, something like that. Okay, Ben, I think it's you.
Thank you. So first of all, I would like to add one thing, like if anyone has any question or has any particular paper we would like to share or has any clinical question, you can send an email to us that is cmiclondon at legendo@gmail.com. If you go on the web, on the Facebook page, there are all the information there on how to contact us.
And Ben, if you can text it in the Q&A, that would be great. But maybe at the end. So go on with the.
Now, tell me if you can see my screen.
Yes.
Okay. So I'm going to carry on talking about adenomyosis. And I found this really nice paper published in 2022 in JMIG, and it's from China, and talks about the efficacy of transabdominal ultrasound scan guided percutaneous microwave ablation for symptomatic adenomyosis. And the reason why I found it interesting is because we all know that the resources that we have for women with suspected adenomyosis that want to preserve the uterus is a little bit limited. But now there are more and more papers about high-intensity focus ultrasound, radiofrequency ablation, and now microwave ablation. So this is a paper that is a retrospective cohort study done between 2019 and 2021. So inclusion criteria were that the patient had to have either abnormal bleeding or pelvic pain. There was a suspected diagnosis of adenomyosis. There weren't any fibroids, and there was a discontinuation of hormonal medication for over 6 months. So I do advise everyone that finds this patient paper interesting to go and read it, because they explain also very well how the percutaneous ablation is performed, and I found it really interesting. So initially, they enrolled 107 patients, 60 of which had non-focal adenomyosis and 47 had focal adenomyosis. But as we all know, during the follow-ups, some of these they stopped answering the questionnaire. So in total, we had 27 patients which completed the 12 months follow-up for focal adenomyosis and 37 for non-focal adenomyosis, and then for they completed the analysis. For the questionnaires, were multiple questionnaires talking about the symptom severity scale, the quality of life, the dysmenorrhea visual analog scale, and the menstrual volume score. We also looked at the complications. So as you can see here, for the first type of complications where you just needed observation and no need for therapy, actually 73% of people had this kind of complication, which was mostly post-operative pain that didn't require any therapy. For the type B, when there was just observation, was 8.4% of patients, and included, for example, patients which had abnormal vaginal discharge with resolved spontaneously. Minor treatment hospitalization for less than 48 hours happened in 2% of cases, and it was, for example, some mild febrile reactions. And the last one, where the hospitalization was for more than 48 hours, for example, for pelvic infection, was in 1.9% of patients. In terms of efficacy of the ablation, actually is quite impressive that the clinical response rate that was seen for either significant complete or partial improvement of pain and or bleeding was 96, 94, and 92% between 3, 6, and 12 months. And also they looked also at other aspects. They saw, for example, a significant reduction of the uterine volume and uterine size of between 40 to 60% after 12 months. The CA125 went down significantly from an average of 100 to 50. The HB of the patients with a reduction of the blood flow during menstrual period improved from 110 to 125, 130, and the dysmenorrhea was reduced from an average of 7 to 8 to 2. So this is and quality of life as well, you can see like improved significantly. So this was a really good study because it opens new possibilities for women with endometriosis, with adenomyosis. Now Kyle is going to carry on presenting this study.
Just to mention there, in case we have some patients in the group, that this is not to be confused with ablation of endometriosis.
Yes.
So this is a microwave ablation for adenomyosis, where excision is not possible. Okay, Kyle.
So I'm going to be talking about data published by a group of surgeons from a number of endometriosis referral centres across Europe. So this was a large international multi-centre study that evaluated complication rates following excision of bowel endometriosis. The rationale for conducting this study was to compare with the comprehensive systematic review published by Professor Bendifala in 2021. Overall complication rates were evaluated and analysed against the volume of activity at respective centres. The complete excision of endometriosis was performed via either rectal shave, discoid excision, or segmental resection. The authors found that the overall complication rate was 5.1%, with no significant correlation observed between the number of procedures performed and overall complication rates. There was a weak but non-significant correlation. There was a high variability of complication rates in low volume centres, and the authors concluded that increased volume may decrease complications, but due to the non-significant correlation, it's difficult to make this data generalizable. It's perhaps more useful for units to compare complication rates to now 2 large published benchmarks. So the slide that Ben's brought up summarised the complications according to mode of excision, so either shave, discoid, or segmental resection. Higher overall complication rates were observed for segmental resection, which is consistent with previously published data, and also complication rates according to unit volume.
That's can we pause here? This is really interesting, Kyle. So, and it's very interesting they've done this. So if you look at the bottom row, you see that centers that were doing less than 40 cases a year had 7.8% complications, and centers who were doing more than 60 a year were having 2.9% complications. And this is what we know. You know, it's everybody knows that volume matters, but this paper, although not statistically significant, but it's really giving us the pointer.
Yeah,
okay.
And actually the next slide summarizes it in a visual way really nicely. So subgroup analysis did show there was a significant difference between group 2 with group 3, but overall no other significant difference was found. But you can see the massive variability in the low volume center versus the high volume centers. The red dotted line represents the quoted complication rates from the literature, specifically the systematic review from Professor Bendifala in 2021. They've done this for all modes of complication, so leak, fistula, hemorrhage, abscess, and going and reading the paper, they've done a really nice job representing it visually.
But it's interesting that going back to that previous slide, because I think we're going to move to Harold's presentation. This is center or surgeon? So they've looked at the whole center doing 60 cases a year, or surgeon? It looks like
this is center.
Center, yeah. And that means they may have, what, 5, 6 different surgeons doing that volume of work.
No,
Again, I think that takes us to the discussion that we were just having with Paco, that what we really, really need, and maybe Harold, Paco, maybe me and you and Paco can get together and discuss how all societies can work towards getting one unified way of collecting data so that we can actually prove what works, what doesn't work, and what language we should use. But that's for another day. Let's go to your
comment, Shaheen. Just a small comment. Yeah. It's not clear what less than 40 means. That could be 5 or 38.
Yes.
So
yes, that's true. That's true. In the UK, we have around 50, 70 now, 70 endometriosis centers. And I think around half of them do a small number per year. And that is centers, not surgeons. That may be more than one surgeon doing that. Okay, so last but not least, Professor Krentor, president of European Endometriosis League and the partner now for LEJ ENDO. So you're not a guest, you're really a host. He's done a really interesting study about morcellation and the timing of morcellation. Please, Harold.
Yeah, thank you so much. First of all, I would like to congratulate you and your team for this fantastic format. And EL is very happy to join forces. And I think this is very important to discuss literature. And I'm really excited to be invited. Thank you so much. What we did was a quite simple study. It was in that time when we all used morcellation, and then we noticed that probably it's not such a good idea to use uncontained morcellation. So then we started to use in-back morcellation by laparoscopy. And just as an introduction, all these are the reasons why we should not do uncontained morcellation. You can have cell spread of adenomyosis, endometriosis, fibroids, and malignant lesions. We all know this, and this guided to the development of different morcellation, in-back morcellation systems. And here are some of the papers published in that time. And the idea of all those is to avoid cell dissemination during the morcellation process. And the idea to do in-back morcellation actually is to continue with a minimally invasive approach without going back to open surgery just because we have a uterus or a fibroid that we would like to get out of our pelvis. So the problem is that in-back morcellation is related to a bit more complex surgery. It's a bit more difficult than doing just the morcellation process without the back. And one of the concerns of all the publications always was the time. So when you look at the early publications about in-back morcellation, and when you discuss this with colleagues, everybody says, yeah, but this takes too much time. So it just takes too much time. And then our experience was that it does not take so much time, and that maybe we are even faster when we do in-back morcellation. So that's why we said, okay, let's see if this is true or not. And we did not measure the time that we spend on back use or back introduction. We just measured the time from the beginning of the surgery, first cut, to the last knot, to the end of the surgery, and compared cases of laparoscopic subtotal hysterectomy with and without in-back morcellation. And here you can see that in 2015 and 16 and 17, we did some cases of uncontained morcellation. And then we started to use in 17 the contained morcellation technique. And these are more or less the numbers that we measured. So it was 107 versus 47 cases. The fastest surgery was 45 minutes. The longest duration more than 200 minutes. Of course, this can be related to, I don't know, adhesions or endometriosis or sacrocolpopexy that you do at the same time. But at the end, the result, when you look at the contained cases, is that you clearly can see a learning curve. When you start, of course, you are slower because you have technical problems. Then after some cases, you get faster and faster by time. So this is one important message. The learning curve is the key point. And when we then compared the last year of our measurement, which was 2018, with all of the contained cases, then we were even faster in using the laparoscopic in-back morcellation. Just to make sure that everybody understands what we are talking about, you introduce a back and then you do the surgery, the part of the morcellation inside of the back. This keeps your pelvis clean. There's no cell spread, no liquid that comes out of the uterus or the fibroid. Of course, it would be possible to discuss the cell safety of those systems, but you don't have to sample. We always checked if the back is intact at the end, and you can do this in even very big uterus. So this was the largest one that we did, almost 1,500 grams in the same back. This has been published too as a case report. And to make it short, the result is that laparoscopic in-back morcellation, of course, consumes time for back use and handling, but it also saves time as it eliminates the need for meticulous sampling of lost tissue fragments, and you do not have to do this complex lavage of the peritoneal cavity. So at the end, the conclusion of our study was that there is no time loss when you use laparoscopic in-back morcellation. And then when we discussed after this publication with our colleagues, we could say, you know, you just have to pass through your learning curve and then you will be the same as fast as before. Thank you.
Thank you very much. Yes, I couldn't agree more, Harold. I think when things happen, big things happen, like the morcellation problem that happened in Boston and led to now, actually, I work for an American hospital group. I can't even use the electrical morcellation because it's banned. But one good thing that came out of it was this bag. And I don't think the bag I'm not worried about the cancer safety. I'm worried about exactly what you explained. That's, you know, you're gathering all the fluid and the little pieces, and also safety of it, as you showed beautifully in your video, that it just pushes the bowel out of the way, and it's much less likely that you will touch something with your. So we've been using the bag with the cold knife morcellation quite a lot recently. And Avril, we did one last week with a uterus 1.7, was it 1 point something? Yeah. And you're right, it takes time, but it's worth it. I think it really worth it. Okay, well, thank you very much. I'm going to just make a couple of announcements and thank the speakers first of all. I'm really, really grateful for people like yourselves, Harold and Paco, very busy clinicians, to have given up your time for this. The next one, so these are easy to remember. Please share this with your team, with your trainees. It's 6th of every month at 6 p.m. London time. So it's very easy. You don't need to check. 6th of every month at 6 London time. We are going to have live surgery on the 25th with Carl Storz. So please follow us on Instagram, YouTube, you know, everywhere. It's CMIG London on Instagram, and it's LEJ ENDO on Facebook. And you will get announcements for the live surgery. It's free for everyone to attend. And just to give you the result of the polls, morcellation, 63% always use bag, 13% have never used bags, and 25% don't ever morcellate. And that's very interesting. I think it is a change that, you know, some people, because of the restrictions in their hospitals or just purely their practice, they never do any morcellations. And if you have papers, this is really important. If you have papers that you want to suggest for us to present, if you want to present yourself on Legendo, please use the email address that Ben has now put on Q&A, and we're very happy to involve everyone. Jamie, who will be presenting in one of our future Legendo ones, is asking, just last question, do you think there is a superior model type of bag to use, either implementation in situ or failure to contain morcellation fragments? Do you think, Harold, there is a better or worse bag?
Well, it's a bit difficult to say because I didn't use all the bags, but the one I'm using, I feel comfortable with the bag, and I think that's the most important thing. You have to feel comfortable with it. Of course, it should be safe, so the number of back lesions should be very low. It doesn't make any sense if at the end you always have a rupture or something like that. So it's important that you feel good with your back, and then you should use it. Using morcellator or cold knife. However, yeah, there are also nice publications on how to use back morcellation transvaginally. So there are many techniques, but I think it's good to contain the tissue and then morcellate it.
Okay, and finally, Paco, do you have any comments on morcellation? You're on mute. Sorry.
Yes. I just want to add that in my opinion, bag is mandatory. You cannot do any more open morcellation. Doesn't matter, as Harold told, doesn't matter which kind of bag do you use. It doesn't matter which kind of technique, knife, cold knife, morcellator, transvaginal, transumbilical. But I think you must do it in a contained way. Not.
I fully agree.
And I don't know. This is. I become philosophical in these situations. How did we not do it before? This is, you know, this is such a simple concept that put it in a bag and then do it in a bag. Why did it take this event in Boston for us to then use bag? And my next philosophical question is, how many other stupid things are we doing and not thinking?
That's the most important question.
Yes, I know.
Because I'm sure there are a lot.
Yes, in 10 years' time, they will say, oh, by the way, you did this for many years. I'm pretty sure, I'm actually very sure that somebody will come up with something that we're doing stupidly and we think it's okay.
I think sometimes we have to ask our colleagues from general surgery, because when they saw us doing morcellation, they always wondered what we are doing.
Yes.
Yeah.
Okay, thank you very much. We're going to close. I really thank you to Harold and Paco. And I also thank my colleagues, Kyle, Avril, Ben, Mikey. A lot of work goes into this. You know, I sort of supervise this, but actually these guys and girls work a lot behind the scenes, and I'm really, really grateful for them. Thank you, and we'll see you on the 6th of April. Good luck with your conference, Paco. Please tell the attendees about Legendo. Please ask them to come and join us.
Sure,
6th of every month.
I will. Thank you.
Bye-bye.
Bye, everybody.
Everyone.
Thank you.
Bye.
Bye.
Right.